Hi, good afternoon. Thank you so much for inviting me. I'm so glad to be here and to share my work with you. And Katya and I have been working on, it really does seem like she's a collaborator with many people. She and I have been working on something that's very similar to what I'm going to be presenting today. And she's really been facilitating a lot of these new connections for me too. So I'm really glad to be here. So the work I'm going to be presenting today is work that I've done in collaboration with a colleague of mine, Nancy Fleischer at the University of Michigan, and another colleague, Georgiana Bostine, who's now at Chapman University. And together we've been studying the smoking trends of Mexican immigrants here in the United States using binational data, which is data that's based here in the United States as well as data that we got from Mexico. A little bit of background, that's probably not a surprise to most of you here, but there is a very strong health advantage that we see among US immigrants. Compared to their US born counterparts, immigrants tend to show better health and health behaviors across a variety of health outcomes: self-rated health, BMI, and smoking, which is the topic of the talk today. The smoking advantage is particularly relevant because some other researchers have found that the lower prevalence of smoking among immigrants can actually explain some of the mortality advantage, which is it's sort of colloquially known as the Latino mortality paradox, where Latinos tend to show lower mortality rates than would be otherwise expected given their socioeconomic status. And in some ways, I think that for people who study immigrant health, the nativity advantage is something that we just sort of take for granted because it's so consistent and it's always there. But if you take a step back, and actually it is really remarkable how robust this advantage is and how much it holds no matter sort of what kind of analysis you do. And so this work that I'm doing really is trying to understand where this advantage comes from. And there's three primary explanations. They sort of group into three kinds of explanations. The first is what I'm calling culturally protective behaviors. And this is the idea that immigrants have some health promoting behaviors that are rooted in cultural orientations. And so these behaviors get reinforced if they live in an area with a lot of co-ethnics, or if they're still sort of practicing a lot of these culturally protective behaviors. The second explanation is that it might be an artifact of data. So a lot of this nativity advantage has been established in these very large data sets. But we know that immigrants, number one, are harder to reach in these surveys. And number two, when you do reach them, they might underreport some certain health conditions, which reflects maybe reduced access to care or maybe some discrepancies with the language. The third explanation for the nativity advantage is health selection. And this works in two ways. So first, sicker immigrants may be leaving the United States, meaning that those who remain are healthier. The second way that health selection might operate is that immigrants are positively selected on health behaviors and health status even before migrating. So in other words, it's the healthier people who come. So the presentation today focuses on health selection and specifically the second kind of health selection. So Yasso has done some theorizing on health selection, and she connects the concept of health selection to the economic theories of migration, which view migration as a balance of costs and benefits. And so she argues that immigrants are positively selected on health compared to their non-migrating peers because healthier individuals are more mobile and they stand to benefit the most economically from migration. But the traditional comparison, the traditional way that health selection has been studied is to use US-based data and to compare immigrants with the US born. And so in certain regression models, after trying to explain away demographic differences, other confounders, or even looking at mediators, other possible explanations for the difference, if there's any sort of residual effect, if it still looks like immigrants show better health, even after controlling for all of these other factors, that difference is usually attributed to health selection. So in other words, it's an indirect measure, right? It's something that is sort of attributed to the results after everything else has been explained for. Right. But the best comparison, the best way to answer this question of is it really the healthiest people who are leaving, is to have a comparison group of non-migrants who stay behind in the country of origin. And so this is an area, this binational study is an area that's really, really growing. And there have been some studies that have used binational data to examine smoking selectivity specifically. And this research has only found weak evidence that immigrants smoke less than Mexican non-migrants, so Mexicans who are still living in Mexico. They find that it's primarily true among men. But the rest of the evidence is really, it's not very strong and it's not very consistent. But I would argue that this body of research overlooks some important factors. And first, it really neglects the aspect of time. So a lot of these studies either only looked at a single time point or they took data that spanned multiple years and sort of averaged across all of these years. But the aspect of time, to overlook it is, I would argue, kind of a big oversight, because we know that the smoking environment in Mexico has changed, right? Much like it has in the United States. So since the early 2000s, Mexico has seen a more restrictive tobacco environment. In 2004, Mexico ratified the WHO Framework Convention on Tobacco Control. And in 2008 and 2009, they passed a series of anti-smoking laws that prohibited indoor smoking. They banned most forms of tobacco-related advertising, and then they required pictorial and text warnings on nicotine products. And then they allowed for some more stricter subnational regulations. So correspondingly, Mexico saw a declining smoking prevalence. So it was 28% in the late 1990s before any of these policies went into effect. It went down to 22% in 2011. And some more recent evidence from 2015 shows that it's actually now gone under 20%. So what do all of these changes in the sending country mean for health selection? Well, it might mean that the extent to which immigrants are health selected on their smoking behavior might change. And if we think that health selection is one of the main contributors to this nativity advantage, the fact that it's dynamic might reduce or enlarge the difference that immigrants have relative to the US born. So there's three different scenarios that we might see as the conditions of the sending country change. First, smoking selectivity might decrease, right, as heterogeneity between immigrants and non-migrants diminishes. So in other words, there's less variation in smoking prevalence overall. So that would just mean a truncating of the difference between the immigrants and the non-immigrants. So this might work, for example, if we know that maybe smoking has gone down in urban areas a lot, but urban areas are actually less likely to be migrant sending areas. So what would happen in that scenario is that the difference between non-migrants and migrants in their smoking would actually go down. The second impact on health selection is that there actually would be no impact, right? So we would see an overall decline in prevalence, but the relative difference between immigrants and non-migrants would stay the same, right? And finally, smoking selectivity could increase, where so the smoking selectivity would increase if the decline in smoking prevalence is concentrated among migrants who are likely to move and immigrants themselves. Right, so individuals who may migrate, because they're sort of thinking about the future, they're thinking about potential future migration steps, they might practice better health behaviors in anticipation of these future opportunities. And so these restrictive tobacco policies would actually reinforce and amplify this behavior. And so we would see greater health selection. But in order to test these patterns, we need to use multiple points of binational data. And so in this particular project that we did, it was just published in Preventive Medicine at the end of last year. We asked the question, how has smoking health selection patterns changed in Mexico between 2000 and 2012? We compared recent Mexican immigrants to the United States with non-migrants still residing in Mexico. But we do acknowledge that non-migrants are a heterogeneous group, right? We can't just compare immigrants to all non-migrants still living in Mexico. So we actually categorized people by their migration likelihood. And we said health selection is present if Mexican immigrants have a lower smoking prevalence than non-migrants. And there should be a gradient where the non-migrants with the highest likelihood of migration have the smallest difference with recent immigrants, and non-migrants with a low likelihood of migration have the biggest difference with recent immigrants. And because of different smoking patterns, we stratified by gender. And so this pictorially is what we think health selection should look like in our different groups. So this picture on top here, we have three different groups. So So this is the US born, or excuse me, the immigrants, and they have the lowest smoking prevalence. Here are the Mexican non-migrants divided into two groups. Here we have the low migration likelihood, and here we have the high migration likelihood. And so there's a larger difference between the Mexican immigrants and those with the low migration likelihood, and a smaller difference between the Mexican immigrants and those with the high migration likelihood. And so if we see changes over time, if nothing happens and if health selection stays the same, maybe just these overall, the length of the bars would change, but the difference should remain the same. But if health selection shrinks, we would see smaller differences across all three bars, or the different groups. And if health selection grows, the differences would also grow. So the data that we used was, as I said, both from Mexico and the United States. The Mexico data was the ENSA 2000 and the ENSA Newt in 2012. These are nationally representative data sources that are similar to the NHANES here in the United States. The ENSA had over 37,000 people. The ENSA Newt had just under 30,000 people. Our US data was from the National Health Interview Survey, and we combined two waves to correspond to each, to correspond to the ENSA, to correspond to the ENSA Newt. So in the first time period, we combined 1999 and 2000 of the NHIS, and that gave us a sample, and we only looked at the Mexican origin sample, and they gave us a sample just above 2000. And in 2012, to correspond with the 2012 ENSA Newt, we combined the 2011 and the 2012 NHIS, and that gave us a sample of just under 6,000. So our dependent variable was smoking status. We divided up into three categories: current smokers, former smokers, and never smokers. And current smokers were defined as people who had smoked at least 100 cigarettes in their lifetime and were still smoking. Former smokers were people who had smoked at least 100 cigarettes in their lifetime but were not currently smoking. And a never smoker was either had never smoked or smoked fewer than 100 cigarettes in their lifetime. I'm just going to be focusing on the comparison between the current smokers and the never smokers. The former and the never smoker results were actually pretty complementary. Our independent variable was migration categories, and we had 6 different migration categories. The first 3 were for the Mexican national non-migrants, and so we divided them up into 3 categories of migration likelihood, so either high migration likelihood, a medium migration likelihood, or a low migration likelihood. And the US Mexicans, the US-based Mexicans, we divided them up to 3 categories: recent Mexican immigrants, so those who were born in Mexico but have come to the United States within the past 10 years. Longer-term Mexican immigrants, again, those who were born in Mexico but had come to the United States at more than 10 years ago, and US-born Mexicans. The recent Mexican immigrants are the key reference group here because we know that smoking patterns change with duration in the United States. So we wanted to limit that change as much as possible. So we chose those within a relatively short duration period, and reasoning that these immigrants would have retained the health selective behaviors. So as I mentioned, we divided up the Mexican population, the Mexican non-migrant sample, by their likelihood of migrating. But the ENSA and ENSA Newt does not collect migration information. So what we had to do is we had to use information from the 2000 and 2010 Mexican censuses, which does contain information on migration. And the migration variable we used in the census was whether anyone in their household moved to the United States in the past 5 years. And we did some sensitivity checks and found that this household migration was actually very highly predictive of individual migration. So we felt pretty confident that this was a good indicator of migration. So in the censuses, we estimated the odds of migration as a function of age squared, gender, marital status, employment, state of residence, municipal level migration rate, and urbanicity. And then once we got those results, we applied that regression equation to the ENSA and the ENSA Newt. And then we calculated a predicted probability of migration for each respondent in the ENSA and ENSA Newt. And we divided that up into tertiles. And so the people in the lowest tertile were those with the lowest likelihood of migrating. The middle was, a medium level of migrating, and those at the highest levels of the probability of migrating were considered the high likelihood of migration. So I'm going to start by showing you some results, and these are just the unadjusted smoking prevalence, current smoking prevalence. I'll show you for each gender and for each time point, and this is for men in 2000. And so what we see here, these 3 gray lines here, are the 3 Mexican national samples. So this here are those with a low migration likelihood, medium, and a high. And we see there's actually very little difference in smoking prevalence across these three categories. But this yellow bar here is the recent immigrants, and there's a huge drop in smoking prevalence. And in 2012, all the bars go down, right? But we still see the overall patterns are actually pretty similar. There's very little difference among the three categories of non-migrants, but there's a huge difference between non-migrants and actual immigrants who are living in the United States and their smoking prevalence. For women, first of all, the y-axis is very different, so their smoking prevalence overall is a lot lower. But we don't actually see very much evidence of smoking selection like we did for the men. For the recent immigrants here actually have a higher smoking prevalence than some of the Mexican non-national, the Mexican non-migrants. And this is in 2000. But in 2012, we start to see a different pattern, right? Where we see this gradient that I spoke about when I was talking about the different hypotheses. And the recent immigrants have the lowest smoking prevalence. So then we ran multivariate regression models. We did multinomial models, and we combined the 2000 and 2012 waves. And our outcomes were the current smokers versus the never smokers, the former smokers versus the never smokers. But I'm only just going to be focusing on the current versus never results. We controlled for age, marital status, education, and employment. Again, we stratified by gender. And we added an interaction between migration categories and survey year. And what this interaction will tell us is whether the differences between these migration categories are different between 2000 and 2012. And so this interaction will really tell us whether or not health selection has changed. And so here are the regression results. This is our reference category here. These are the recent immigrants who've been in the United States for less than 10 years. And here are the Mexican nationals, low, medium, and high likelihood. And if you look at the odds ratios, they're all very similar to each other, much higher than the reference category. So it means that these people here have a higher odds of smoking, and there's not very much variation across them. But because we have an interaction term, these are the results for the 2000 data. And what the interaction term tells us is whether or not these same patterns are consistent in 2012. And so if you look at the confidence intervals for all of the interaction terms, they cross 1, right, which means that they're not significant. So it looks like the same patterns that we see in 2000 are also being replicated in 2012. And so this is a graph of the predicted probabilities based on that model that I just showed you. And if you look here, this is 2000 and this is 2012. The two pictures actually look pretty similar. Down here, these are the Mexican non-migrants. These are those with low migration likelihood, medium, and high likelihood. Here are the recent immigrants. I'm just going to actually be focusing on this comparison here and then these, ignoring for a minute the 10 plus years in the US born. And so actually, if you look at 2000 and 2012, they look very similar. The lines here across the non-migrants are basically flat, right? But we see a huge drop when we take into consideration recent immigrants, right? And so although everything is sort of adjusted down in 2012, it looks like the differences among the different groups stay pretty consistent. So for women, here again, there's the same results except for women. Again, here's our reference group, which is the recent immigrants. And here are our 3 Mexican national groups divided up by migration likelihood. And if you take a look at the confidence intervals, we see that they all cross 1. And so what that means is that all of these Mexican national groups, none of them are statistically different in terms of smoking than the reference category, right? So there's no differences in smoking for women between Mexican migrants and Mexican non-migrants, right? No matter how you divide up the non-migrants. The interaction terms at the bottom, though, tell a little bit of a different story. So this is specific to 2000. The interaction terms tells us whether or not those patterns have stayed the same across those 2 time periods. And if you see, one of the interaction terms actually is significantly higher than 1, which is the interaction for Mexican nationals with a low likelihood, right? And so if you look at the graphs, it tells this story a little bit more intuitively. What happens in 2000 is that this is the the estimate for recent immigrants, right? And you can see that there's no significant difference in smoking between recent immigrants and any of the Mexican national groups. But here in 2000, we see that there's growing evidence of health selection, right? Because they have lower smoking prevalence than this group right here, which are those with the lowest likelihood of migration, right? So we're starting to see evidence more of this gradient, and this difference between recent immigrants and Mexican nationals is actually starting to grow. So what can we say? Well, recent immigrants have lower smoking prevalence than their non-migrant counterparts, and this is especially true for men, right? But the question about changing selectivity over time, given the changing tobacco environment in Mexico, it really only seems to affect the women. We saw increased selectivity among women only, right? Didn't seem to be any difference in smoking behavior in 2000, but in 2012, we started to see a bigger difference between recent immigrants and non-migrants still living in Mexico. For men, overall smoking prevalence decreased, right? So it was this first scenario that I was talking about, or the second scenario I was talking about, where the patterns, everything is lower, the bars are lower, but the patterns really stays the same. So why do we see differences in gender? Well, there's a couple reasons why, well, a few reasons why we think why women might have been a little bit more sensitive to the changing tobacco environment than men. The first is that men and women, I mean, it's pretty clear, but they have very different smoking patterns. So men have a much higher smoking prevalence than women do. And so for men, it could just be that because their smoking prevalence was just higher to begin with, these sort of broad population level tobacco controls they serve the function of just bringing down smoking for everybody. But for women, if you actually look at the prevalence of smoking between 2000 and 2012 in Mexico overall, not even thinking about differences by migration likelihood, it was actually pretty consistent. And so we were thinking that it's low. It was under 10%. And so we were thinking that, well, maybe what happens is that because it's this lower prevalence, it just might be more sensitive to population differences. The second possibility is that women lag in the stages of the smoking transition. So the smoking transition is sort of this global pattern where as countries develop, men have an earlier uptake of smoking, but then they also have an earlier reduction of smoking. And this is sort of just these general trends, other things sort of being equal. So it's possible that maybe our time period was not capturing this shift in reduction of smoking that men experience. So it could be that they maybe did have increased selectivity, but it happened before 2000. And finally, there could have just been cohort effects among the women. So women, we've noticed that the women in 2000 and the women in 2012 actually looked a little bit different. Women had more education in 2012. They were more likely to be employed. So it could be that there's something about the cohort effects. They're actually different groups of people. And so that might be creating sort of a cohort effect that we saw in 2012. So the goal of this paper, what I just presented to you, was really just to test this idea of health selection, which is this question of, is it really the healthiest people who are leaving, right? And in order to do that, you need to have the comparison of migrants compared to non-migrants, right? But as immigrant health researchers, we're actually interested in health selection because we think it might give us some insight into the nativity advantage, right? Which is a different comparison. That's immigrants versus the US born, right? And so fortunately in this data set, we're actually able to make these comparisons simultaneously. So I can't statistically account for health selection and see if it sort of explains away the difference between the recent immigrants and the US born. But what we can do is sort of make these comparisons in parallel and see if they're complementing each other, if we really do think that health selection is one of the drivers of the nativity advantage. So these are the same results, except now I didn't show the results for the other two US-based groups, the longer-term immigrants and the US born. Because I just sort of wanted to focus on the comparison between migrants and non-migrants. But here are the full results now with the comparison with the US-born Mexicans. And so what we see in 2000 is that this is our reference category here. Again, it's recent immigrants. And what we see is that US-born Mexicans do have a higher likelihood of smoking, right? And then here's the interaction. We see that that difference doesn't seem to change between 2000 and 2012. And for women, we see that compared to recent immigrants, US-born migrants, although the point estimate is higher, right, it crosses 1. And so there's not a statistically significant difference in smoking between recent immigrants and the US-born. So there doesn't seem to be a nativity advantage for women in 2000, right? And if we're looking at the interaction term, it looks like the story is pretty much the same in 2012, right? So there's no nativity advantage in 2000, and there's no nativity advantage in 2012 for women. So if we take those two parallel comparisons and we sort of look at them together, what does this tell us about the implications of health selection for the nativity advantage? Well, first, for men, it tells us that recent immigrants have a lower risk of smoking than for the US-born. And the difference between recent immigrants and the US-born was not statistically different at the 2 time points, right? And so that actually corresponds well to what we found with health selection. We found that health selection for men was the same. It was present in 2000, and it was present in 2012. And likewise, we saw that the nativity advantage was present in 2000 and present in 2012, right? And so at least there's sort of this indirect evidence that these two patterns are sort of moving in parallel with each other, which is what we would hope, right, if health selection really is a driver of the nativity advantage. For women, though, there was no evidence of the nativity advantage in 2000, right? And the same thing was true in 2012, although it does look like the trend seems to indicate a larger difference in 2012. If you look at the interaction term, I mean, it is above 1, right? So it looks like that difference is growing in 2012, but it hasn't reached the point of significance, right? So what can we say about the growing health selection in 2012 for women? Is it really, it's not clear whether or not it's actually going to contribute to a nativity advantage. Later on, it could be that maybe just women's smoking prevalence is just so low to begin with that any sort of difference that migrants have compared to non-migrating Mexicans is not really contributing to that. So what are some overall health conclusions? Well, health selection as a theory is valid, right? It does look like, especially for men, it is the healthier people who are leaving, right? But health selection seems to be somewhat not as robust as we would hope, right? It doesn't seem to be as robust for women. And it seems to be a little bit time dependent for women. The patterns of health selection do somewhat align with the patterns of the nativity advantage, right? But those are really gross comparisons, kind of making a lot of assumptions, right? And we just want to see if the patterns of health selection are sort of aligning with the nativity advantage at both time points, right? But we do know, for example, that the United States, between these 2 time points, was also experiencing a very drastic change in its own policy and in its own tobacco environment, right? And so trying to pin down exactly what health selection does for the nativity advantage is it's a little bit of a moving target, right? And so in order to do that, you need a much more complex picture of what's happening to immigrants as they stay in the United States with longer residence, as well as considering, well, what's happening in the US environment, right? And is that affecting immigrants differentially compared to US-born? So I wanted just to talk about one last thing, thinking about, well, how do we explain this nativity advantage? And I feel like if I had to think about my research, and I really appreciate what you said in the beginning, that immigrants, we tend to think about health disparities and we tend to think about ways in which they're disadvantaged, but the nativity advantage is actually really strong, and it's something that we have to understand more. What is it that actually makes immigrants have better health than the US-born, right? And so I've looked at this idea of health selection, and in theory, it seems like it could potentially be an explanation, right? But we have a long way to go in trying to actually connect health selection to the nativity advantage itself, right? But another way I've tried to understand this health selection, the nativity advantage, is to try to see, well, if we know that the US smoking environment is changing, right, is it affecting the US-born more than it is the immigrant? So in other words, is the nativity advantage staying constant over time? And if you look at just the men's, and one thing we found really interesting about the study that I just presented is that even though house selection seemed to stay pretty constant for the men, what was interesting is that their overall smoking levels were going down, right? And so my colleagues and I, the ones who we worked on this paper with, started thinking about, well, what does the decreased smoking prevalence mean for these duration trends? What does it mean when immigrants come in with lower smoking? How does it affect their smoking behaviors once they're here in the United States? So we asked, well, does the nativity advantage stay constant as immigrants, number one, are coming in with lower smoking, right? Number two, stay in the United States. We know that there are these duration patterns, right? So that health behaviors change as immigrants stay longer in the United States. And number three, that the US born are also experiencing a decline in smoking because we have, very similarly to Mexico, we've instituted these very broad population level anti-smoking policies, right? And so what we did is we used that same study, which was the NHIS, the National Health Interview Survey, but this time we took 4 waves. And we only looked at men because the smoking data for the women the prevalence was really low, so we were getting really unstable estimates. So we only looked at men. And what we did is we followed 4 cohorts of men through different time points. So what we did is we looked at men who entered the United States in 1998. Actually, I'm going to use this instead. Who entered the United States in 1998, and we followed them at the point of migration, which they were here for 0 to 4 years. We followed them 5 years later, once they had been in the United States for 5 to 9 years, and then again, once they had been in the United States for 10 to 14 years. And then we did the same thing for the cohort of immigrants entering in 2003, and we followed them at 3 time points. Once this 0 to 4, we're just assuming that's at the point of entry. Again, when they had been here between 5 to 9 years, and when they had been here between 10 to 14 years. And the last cohort, because we only looked up to 2013, we were only able to follow them at 2 time points, once at the point of migration, and then one more time after they had been here between 5 to 9 years. And for all of these points, we always have a US comparison. So we want to see, number one, if for each of these cohorts who we follow, what is their comparison like to the US born? And is it changing over time? And so I'm just going to show you, I'm not going to show you any numbers, but I'm just going to show you our graph. And here's, on the y-axis is the predicted probability of smoking. And again, this is only for men. The solid line here is the US born. And if you just focus on the US born, you can see that it's actually going down. This y-axis is pretty big, it's 0 to 50, but it's a 10-point difference, right, between 1998 and 2013. So for US-born Mexican men, their overall smoking prevalence has gone down 10 percentage points, which is actually pretty high, right? But we also know that immigrants are coming in with lower smoking because they're receiving it at 2 ends, right? They're receiving anti-smoking policies before they leave, and they're entering an environment that is also starting to crack down on smoking. So if you look over time, this is the first cohort. This is who entered at 1998. And what's surprising is that, so these are folks who came in to the United States before these anti-tobacco policies were enacted, right? And so they have the highest levels coming in. But what you see is as they spend more time in the United States, it drops dramatically, right? And if you compare to the US born, they experience a drop that's even higher than their US born counterparts, right? But what's happening with these cohorts who are entering later is that, number one, they're coming in with lower smoking, right? But their patterns over time look very similar to the US born. So what we think is happening is that because these folks here are already sort of receiving messages and they're leaving Mexico where these anti-tobacco policies are being enforced, when they come here to the United States, it's a little bit of like more of the same, right? So they're environmentally, they're subject to the same kind of policies, right? So what can we take from this? Well, overall, even though both the tobacco environments in Mexico and the United States are experiencing rapid change, right? The good news is that it looks like the advantage the advantage that immigrants display compared to the US born seems pretty consistent, and it seems really robust, even though there's so many changes in both the sending and receiving countries. Okay, so this is just everything I just said. So So I'm going to stop here and see if anybody have any questions.